Good afternoon. My name is Julio Nemirovsky. I am geriatrician doctor and president of the Argentine Society of Gerontology and Geriatrics. It is an honor to be able to introduce Dr. John Morley. All of us who travel the path of research in areas as sensitive to geriatric as frailty, sarcopenia, behavioral disorders, and diabetes are nourished by his multiple books, scientific communication, and professional opinions. Johnny Morley, MB, BCH, is a professor of internal medicine in the Division of Geriatric Medicine at St. Louis University School of Medicine. He has edited more than 20 books and published more than 1,400 papers, with major research emphasis on the role of the neuropeptides in the modulation of hormonal responses and behavior. Clinical, he focuses on diabetes, nutrition, frailty, sarcopenia, cachexia, and cognitive assessment. Dr. Morley's lecture entitled as The Rapid Geriatric Assessment. Dr. Morley, we listen to you. Thank you.
Today we're going to be talking on the rapid geriatric assessment. This is a test that's been evolving at St. Louis University for primary care physicians to screen older people in the community, to find problems and, where possible, treat them. This is particularly because of the shortage of geriatricians. As we all know, at this meeting in particular, the population is getting older, and many of the population are living into their 80s, such as people in Japan, Hong Kong, Singapore, Australia, France, Korea. And then there are people in the United States who haven't quite made it towards their 80s, but finish up around about 79 when you add the males to the females. Jeanne Calment up there is the world's oldest woman. She lived into her early 120s and functioned really well throughout her life. Bob Dylan had a song, The Times They Are Changing, and this is where we're getting to now after the COVID epidemic. Come gather around people wherever you roam and admit that the waters around you have grown, and accept that soon you'll be drenched to the bone. If your time to you is worth saving, then better start swimming or you'll sink like a stone, for the times they are changing. As we all know, we're in the middle of an aging tsunami, decreased slightly by the COVID epidemic, and old age medicine is different, and it's important that all healthcare providers recognize these differences. There is, as I have mentioned already, a shortage of geriatricians around the world. The United Kingdom and France have the most geriatricians. In the United States, we have 1.5 geriatricians for 10,000 of the population over 65. When I became a geriatrician, there were nearly 6,000 geriatricians, and that number has decreased in the United States to 3,590. We also lack interprofessional teams. There's a lack of gerontological programs and a lack of geriatric education. So it is important that we develop systems where we can make it relatively easy for the primary care physician to look after older people. When we think about old age and frailty, we have to realize that it is both complicated and complex. Sending a woman or a man to Mars is complicated, but when you're managing a frail older person in hospital or at home, it is both complex and complicated, so we have to put the two together. And when we think of why the care is so complex for older people, transitions between care can be very complicated. Finding meaningful non-pharmacological interventions is difficult. Poor coordination exists between care providers in most countries. Barriers of certain communication as we get older can be language, hearing, and speech, and there's limited recognition and treatment of the geriatric syndromes. When you look at an older person, you have to do primary, secondary, and tertiary prevention. It needs to focus on the human team care, and overall around the world, geriatric care is poorly reimbursed and compared to giving people medications. So to try and get around this, at St. Louis University, we developed the Rapid Geriatric Assessment, which consists of 5 main components. The one is a screen for frailty. The next is the SARC-F, a screen for sarcopenia. The SNAC is a screen for anorexia and malnutrition. And the rapid cognitive screens for cognitive problems. And then we also need to know what the person would like us to do, depending on what is going on with them. Always like to start when I talk about older people to quote this poem, The Cat in the Hat on Aging. I cannot see, I cannot pee, I cannot chew, I cannot screw. Oh my God, what can I do? My memory shrinks, my hearing stinks, no sense of smell. I look like hell. My mood is bad, can you tell? My body's drooping, have trouble pooping. The golden years have come at last. The golden years can kiss my, whatever. Yes, so we have to recognize many things change as we're getting older, and many of these can be reversed. We look at what happens in a super sports person. If we're looking at the English football players, the age at which they peak is around about 25 to 30. And then after that, they go down, and they go down at a rate of about 0.5% to 1% per year. All of us do about the same thing. We peak around 30, and then slowly in all our facilities, we decrease our function. If you look on the right-hand side of this graph, you see the same thing shown for VO2 max, cardiac output, balance, muscle strength, peaking somewhat around about 30. After 30, it tends to go down at that 0.5% per year. If we do exercise, we can slow the rate it goes down. If we get diseased, it goes down quicker to the frailty threshold and then to disability. So how do we define frailty? Frailty was defined way back when it was said that it occurs when under stressful conditions, the person has diminished ability to carry out important practice social activities of daily living. It should be distinguished from disability. And the first definition of physical frailty was made by Linda Fried at Johns Hopkins. And she said that if you lose more than 10 pounds of weight in a year, if you self-report that you're exhausted, if your grip strength is in the lowest 20, if your walking speed is in the slowest 20%, and you have low physical activity, if you have any of these, you're liable to be frail. And the more you have, the more likely you are to be physically frail. Females tend to have a slightly higher rate of physical frailty than males. And when you look at it, relatively healthy people in their 70s, just under 7% are going to have some degree of frailty. So to try and put this into a very simple format, we came up with the FRAIL, with the International Association of Aging. And what we said is, if you're fatigued, if you cannot climb a flight of stairs, if you cannot walk 1 block, if you have more than 5 illnesses, and if you've lost greater than 5% of weight in 6 months, you have 1 or 2 of these, you're pre-frail. 3 or more makes you frail. And at this stage, there are now many more than 35 validations around the world showing that this frail, simplified version is highly predictive of poor outcomes in older people. After we had published this, Leon Flicker from Perth in Australia sent a paper to the Journal of Clinical Endocrinology and Metabolism, and he had used FRAIL to show that it related to testosterone. And one of the reviewers wrote back to him and said, but FRAIL has never been validated. So the first validation of the FRAIL came from Leon Fricker in Perth. Many people have validated it since. One of the best validations was done by Jean Wu. She showed that the FRAIL scale was equally specific to the Rockwood, the cardiovascular health scale, that's Fried scale, or the Hubbard, and this was true both for physical, for mortality in both males and females. In St. Louis, we looked at a younger group starting between 50 to 65, and we followed them for 9 years. And what we found in this group, that the frail was highly predictive of poor ability to carry out the daily activities of living, and also predicted mortality. And again, it did very well compared to the other frailty scales around. We looked in Missouri at over 10,000 people around the state. And what we found is that when you looked at the screening, basically, physician screening, about 20% were frail. If you came to a non-physician screening, people who came tended to be frailer. Nursing homes, about 70% were frail, and in hospitals, again, about 45%. Frail increases with aging, going from about 23% in the 65 to 74-year-old to 40% in those 85 and plus. We need to look for and find some nice physical markers of frailty. Working with Andy Wynn in our group, we showed that progranulin, which is a marker of inflammatory disease, is a good measure of picking up those people who are frail by either the frail, the CHS, or the frailty index, and that it correlates very well with inflammatory cytokines. So we think that you can use progranulin as a biomarker for frailty. So once we've made the diagnosis of frail, the important thing in doing a screening test is that it leads you to being able to do different reversible therapeutic mechanisms. The aged care minister, Ken Wyatt in Australia, basically said that frailty screening should be looked at as a canary in the coal mine, and that looking for it in older people is a game changer, and that once you find it, frailty can be halted or even reversed by safe and simple mechanisms. So we have to recognize we can do this. And if we look now on the left-hand side, we have the frail screener there. And if you report that you're frail, fatigued, we have to look for whether you're depressed. Do you have sleep apnea, hypothyroidism, or B12 deficiency? Are you anemic? And do you have hypotension or orthostasis? Obviously, the resistance and aerobic are looking for sarcopenia. And if that's the case, we need to listen to the physician or healthcare professional who will tell us to do resistance exercise and aerobic exercise 3 to 5 times a week. If we have more than 5 illnesses, this is a proxy for polypharmacy. And in previous studies, we've shown that people who have 5 or more illnesses, medicines, tend to do badly. They're often on anticholinergic and other drugs that are negative for older people, and drug reduction is important. And then the other big piece of frailty is loss of weight, and we'll talk about that in a minute. Remember that if the person's fatigued, you need to screen for depression. The best screen for depression is the PHQ-9. Scores greater than 18 require treatment. And if a person's depressed, you should always ask about loneliness, and we'll talk a little bit more about loneliness towards the end of this lecture. Sleep apnea, it's, again, a person who's fatigued, you can do the stop and bang screener or the Epworth sleepiness scale, but people with sleep apnea are very commonly frail. In our community studies, we find about 1 in 10 people who score positively on the frail scale have sleep apnea, and it's extremely important that we actually pick these people up and treat them early. So After frailty, the next geriatric syndrome we want to look at is sarcopenia, which is poor function associated with muscle loss. Sarcopenia is recognized as an independent condition by the International Classification of Disease, the ICD-10, and it's important because this means that we can actually bill for its screening and also for treating it. If you look down there at the bottom, you see a relatively famous movie star who became the governor of California, and you can see when he was a movie star, he had great muscles. In his 50s as governor of California, he was showing fairly clear beginnings of sarcopenia. Perhaps the best example of sarcopenia is Olga Kotelko. She was a 90-year-old long jumper. She could jump 1.5 meters. This is in comparison to women high school champions of 6.9 meters and the women's world record of 7.5 meters. So where did sarcopenia come from? It was first described in the 40s by MacDonald Critchley, who noticed that as we got older, we had wasting of our hands and feet, and he thought that this was an important thing to look at. In 1988, at a meeting in Albuquerque in New Mexico, Erwin Rosenberg from Boston was the first to use the term sarcopenia, pointing out that people who were losing muscle had poor outcomes. There are many causes of sarcopenia, as are shown on this slide, and if you want to look at it, decreased physical activity is certainly one of them. But another is mitochondrial activities. And recently it's become very clear that a number of small RNAs play a major role. So take as an example, the MOTS-C mitochondrial RNA decreases myostatin. By doing this, it prevents the loss of skeletal muscle. When myostatin goes up, you get skeletal muscle loss. Multiple mitochondrial abnormalities have been shown to cause sarcopenia. If you have inflammatory disease, cytokine excess, such as TNF-alpha or IL-6, you again will get sarcopenia. If you lose your testosterone, your DHEA, you're going to become sarcopenic. People who are vitamin D deficient will become sarcopenic. If you have decreased growth hormone and ghrelin, this will lead to a decrease in insulin growth factor 1 and muscle growth factor, which will lead to loss of muscle. If you have, as you get older, decreased ciliary neurotrophic factor, this is particularly common in diabetics, you'll have decreased motor units. When you have decreased motor unit activity, you lose muscle. If you have hypoxia, you will tend to lose muscle. As we get older, basically, we have more fat in our muscle, and that decreases muscle function, also made worse by insulin resistance. If you have visceral obesity, you'll see that you have an increased leptin, which decreases caloric and protein intake. And then there are a number of genetic peptides that affect the muscle and cause muscle loss. So many, many causes of muscle loss. We need to pay attention to this. So how do we measure muscle loss? Originally, it was measured by bioelectrical impedance. This is not a very good way to do it. Then we went on to people using DEXA. This was Baumgartner first did it at the University of New Mexico. It's a pretty good way to look for loss of muscle. Ultrasound is also very good. But recently, tritiated creatine has been shown to be an excellent way, the creatine dilution method, of looking at muscle loss. And all of these are important. It's important to measure muscle loss when you think the person might have it. And the problem is these are difficult tests sometimes to get. They're expensive, they're time consuming. And so because of this, we came up with the SARC-F screen for sarcopenia, which is strength, difficulty in carrying 10 pounds, assistance in walking, how difficult is it to walk across a room, rise from a chair, can you transfer from a chair or bed, climb stairs, how much difficulty do you have climbing a flight of 10 stairs, and falls, how many times have you fallen in the last year? If you have a score of 4 or more, you're classified as having sarcopenia. And on the right-hand side, as you're looking at it, you can see a study done in Japan. They compared SARC-F greater than 4 to SARC-F less than 4, and they showed that the people with SARC-F greater than 4 had the worse grip strength, worse quadriceps strength, worse one-leg standing, worse SPPB, slower usual gait speed, and their 6-minute walking disease was less. Should point out that we have shown, and we'll show you some more of this, but in our study in Perry County, we found that if you had a SARC-F greater than 4 and you went into an exercise program, you could reduce this into a normal range level. So exercise is an important way to reverse it. Other studies showing that SARC-F is highly predictive of poor outcomes. A study we did with Luigi Ferrucci up in Baltimore showed that SARC-F is highly predictive of ADLs, IADLs, and grip strength. In St. Louis, African American study with Ted Malmstrom, we showed that SARC-F predicted IADLs, chair stands, grip strength, SPPB, and gait speed. And Jean Wu did a wonderful study where she looked at the odds ratio for 4-year outcomes associated with sarcopenia in Hong Kong. And you can see that using the SARC-F, basically, it was highly predictive of physical limitation, chair stand, and walking speed, both in men and women. And it was better than any of the other frail scales or sarcopenic scales that were available. When we looked in our Missouri population, we found that about 1/3 of older people coming to the physician were sarcopenic. Looking in the community, and here we were looking at rest homes and other places, about 49% had it. In the nursing home, 82% were sarcopenic, and the hospitals about 50%. SARC-F is now set out as a screening test for sarcopenia by the SCWD, the Society for Sarcopenia, Cachexia, and Wasting Disorders, the European Working Group on Sarcopenia in Older People, and the Society of Sarcopenia and Cachexia and Frailty. So we have to recognize this has been shown to work really well to pick up people with sarcopenia. I mentioned our Perry County exercise program, and you can see here over a 12-month period that the 5 times sit to stand, the time up and go, and hand grip strength were all greatly improved by exercise. At Perry County, they've also introduced the Helsinki University Research Exercise Machine for people who cannot stand, don't do well at walking, and they are finding that they are getting excellent results with the HER machine as well. Where else has this been done? So we can look in Singapore. Professor Risham Merchant basically has this happy program that they do in the high-rise buildings in Singapore, works extraordinarily well. And Jean Wu with the cadenza study in Hong Kong showed excellent outcomes with exercise. And again, there's another program in Singapore, the Gym Tonic program, which has shown great improvement. So exercise makes a big difference to people with sarcopenia. A number of drugs have been developed to treat sarcopenia: anabolic steroids, growth hormone and ghrelin analogs, myostatin activin antagonists, vitamin D, beta-adrenergic blockers, metformin, mast receptor activators, stem cells, and even CRISPR. And what the studies have shown is, of these, testosterone as an anabolic steroid does very well, but it doesn't do any better than exercise. So exercise does as well as any of these drugs. And when we compare it to basically bimagrumab, a myostatin-type drug, again, exercise is better. So exercise is the treatment of choice for sarcopenia. And in some people who have ability not to walk or lost limbs, we can look at developing and putting into place the exoskeleton. And when the World Cup soccer championship was in Brazil, the first ball was kicked out by an older male who was wearing an exoskeleton. So to summarize where we are with sarcopenia, this is the SCWD position paper. Healthcare professionals are encouraged to screen for sarcopenia using simple screening tools such as the SARC-F. Where available and feasible, physicians should make a formal diagnosis of sarcopenia utilizing grip strength or chair stand if available, and then do a measurement of fat-free mass. Resistance exercise should be the first thing to be prescribed. Protein intake of 1 to 1.5 kilograms per day should be in conjunction with a physical exercise. And there's insufficient evidence to say that pharmacological agents are better than exercise at this moment in time. Now we go to the anorexia of aging. As Mahatma Gandhi pointed out, to a man with an empty stomach, food is God. And the first definition of anorexia of aging was made by Cicero, who said he was grateful for old age because it had made him more interested in good conversation and less interested in food. Andy Silver, when he was working with me, did a large number of studies showing that the anorexia of aging has multiple causes. Much of these are associated with a decline in adaptive relaxation in the stomach with a decreased rate of gastric emptying. The increase in cholecystokinin is important. A decline in testosterone with the increase in leptin, and then alterations in smell and taste. And then within the central nervous system, decreased food intake is mediated by changes in opioids, and neuropeptide Y and nitric oxide in the brain, all of which go down with aging. So we know that anorexia in older people independently predicts mortality, and we screen for this with the SNAC. Professor Wilson and Thomas were the people who did this with me originally, and we basically pointed out that you can do 5 very simple questions, and at the end of these simple questions, you can pick up whether or not the person is going to lose weight over the next 6 months. And again, when we look in Missouri, about a third of people, older people in the community, have anorexia, higher numbers in the nursing home. How do we treat anorexia of aging? We try and increase food with good tasting foods, and we also use the Meals on Wheels mnemonic to pick up reversible causes of weight loss, such as medications, emotional depression, alcoholism, anorexia tardive, and elder abuse, late life paranoia, swallowing problems, oral problems, nosocomial infections, and no money or poverty, wandering, dementia, hypothyroidism, hypercalcemia, and hyperadrenaline, or the metabolic causes, malabsorption or enteric problems, celiac disease in particular, eating problems such as a tremor, and older people with a tremor can't get food to their mouth, therapeutic diets such as the low salt, low cholesterol diet, shopping and meal preparation problems, and then importantly, always look for cholecystitis or stones. When I developed my gallbladder disease, I lost 70 pounds before I could accept that I needed surgery, and it's a great way to lose weight, and most of it I managed to put on afterwards. The final geriatric syndrome that we screen quickly for is going to be cognition. Memory is a passion no less powerful or pervasive than love, healing vessels or rivers run to the sea. And we have to recognize that in older people, about 45% who have memory problems will have Alzheimer's disease, a third will have vascular-based lesions, and about 10% Lewy body, and then there are about 90 other causes of dementia. And we need to recognize that dementia has been decreasing in the United States, and this is almost certainly because of aggressive treatment in middle age of cardiovascular disease, both hypertension and hyperlipidemia. But things have changed with COVID, and we're now seeing an increase in cognitive dysfunction anyhow following the COVID. So how do we screen for cognition? Basically, originally, Falstein came up with a mini mental status examination. It's educationally dependent. You get both false positives and false negatives, and it has minimal testing of visual spatial system. It works, however, very well, except when Falstein retired, he decided that he would get a lawyer to go around charging people for this. This annoyed me, and the only other test that was out there that worked well was the Montreal Cognitive Assessment, which you have to pay to be trained before you can use it. So we came up at St. Louis University with the SLUMS, the St. Louis University Mental Status Examination, which picks up much better fundamentally MCI as well as dementia compared to the mini mental status exam. And then we realized that it was taking 6 to 10 minutes to do, which was too long for the primary care physician. So we came up with a primary cognitive screen, the rapid cognitive screen, which is 5 words. We then ask you to draw a clock and put the hour markers and the time on it at 10 to 11. Then remember the 5 words. And then we have a paragraph that we read about Jill, a successful stockbroker. She made a lot of money, but she lived in Chicago, so on and so forth. And in the end, you ask, what state did she live in? The answer obviously being Chicago. If you are in Argentina, you might want to say what country and put the town in Rio de Janeiro or something. You have to put these near, and this is much better than the mini-cog at diagnosing dementia, but particularly mild cognitive impairment. And in our screenings in Missouri, we found that about 22% of people seeing a physician over the age of 65 have MCI. I have dementia, and another 20% MCI. In nursing homes, obviously, you're going to see more dementia, and in hospitals, a higher rate. What do you do with cognition? Well, the first thing is that data has shown that polyphenols, which are predominantly in fruits, do a wonderful job at decreasing dementia. And so the Mediterranean diet has been associated with a reduced risk of Alzheimer's disease. And basically in Finland, the FINGER study recruited people aged 60 to 77 years from a national survey. They did a 2-year multi-domain intervention of diet, exercise, cognitive training, vascular risk monitoring, and they had a control group. And basically they showed that the intervention group had less deterioration of memory as they got older. We have been very happy working with Martin Orrell's cognitive stimulation therapy test, which comes out of the University of London. When Martin first came to visit us, we set up a study in the NHC nursing home and showed marked improvements in nursing home patients who received cognitive stimulation therapy. And subsequently in Perry County and now in Kirksville and other parts of Missouri, we have shown that basically if you do CST on populations, you will get at least as good an improvement as you get with the drugs available for treating Alzheimer's disease. In Scotland, Dr. Tolson and her colleagues have shown that football or soccer reminiscence interventions improve outcome. And we, with Nina Tomosa here in St. Louis, we showed amongst groups of veterans that basically if we did a cardinal reminiscence, a baseball reminiscence, they had good outcomes. So if you put together a Mediterranean type diet, exercise, and some brain games, you find that you get fairly good improvement in cognition in many older people. So this is important to look at as we go forward. However, I have to include this because Jeff Scher with us basically went ahead and did a number of epidemiological studies. And what he showed with these studies are that basically herpes zoster vaccine and Tdap vaccine basically are associated with a reduction of new onset dementia, and it reduces the dementia by about 50%. There's no drug, there's no treatment that does as well as that. And we wanted to see if this was true also in animals. So we used our Alzheimer animal, the SAMP8 mouse, and we gave it Tdap. And what you see over there with the Tdap is that basically we totally stopped the development of fundamentally dementia in the SAMP8 mouse, the Alzheimer's model, and this was because of a change in T regulatory cells. We're now looking to see if we can understand how that modulates inflammation, but we think that's how it does. So other things to realize is we've mentioned social isolation, the loneliness epidemic. Our Surgeon General said during my years caring for patients, the most common pathology I saw was not heart disease or diabetes, it was loneliness. And as you can see on the left-hand side, loneliness leads to a large number of poor outcomes. No one should be alone in old age, but it is often unavoidable. And the studies by Petkalka and her colleagues in Finland have shown that a circle of friends is a good way to bring people together and alleviate loneliness. And recently we have published the Alone Scale, which is a very quick way to pick up whether or not a person is lonely and to put them into some form of social intervention to try and stop depression and improve outcomes. So as we come to the end, basically what we need for the future is shown with the rapid geriatric assessment. It's a patient-centered medicine where you're going to basically pick up what's going on and you're going to put the person in a high-quality, age-friendly healthcare system which will treat the different components of the rapid geriatric assessment if you have them. And clearly, we will see that with computer assistance, you will have better outcomes. Rishma Merchant, Professor Merchant in Singapore, has done this with an iPad screening with excellent outcomes in Singapore. And we have developed a part of the rapid geriatric assessment along with some of the other tests that we use at St. Louis University to show that in the annual wellness visit, you can pick up things that are wrong with a person that are treatable. And the focus is totally on treatable things. Please try and remember in older people, you would like to find treatable things that are reversible. And remember that exercise is most probably the single most reversible commodity we have in older people. So to conclude, we are going into an aging-friendly world. It has to be patient-centered. Geriatrics is a team sport. We have a whole new world that is coming for older people. And we have to remember every older person is different. So screening with the rapid geriatric assessment and then treating this individual geriatric problems that we find is the way that you can improve outcome in older people. Thank you very much.
Thank you very much, Dr. Morley. Your presentation always allows us to advance in the identification of the issues that most concern us geriatricians. Thank you. Thank you very much. Thank you again, Dr. Morley, for sharing your knowledge and experience with us. I seen the image of the governor of California convinced me not to run for governor. It is useful to determine sarcopenia as a frailty biomarker.
I think it's more than a frailty marker. In our experience, about half of the people who have frailty have sarcopenia, and equally about half of the people who have sarcopenia have frailty. Sarcopenia exists on its own to some extent, so you may not be too frail. The importance of early recognition is that you can decrease the chances of a person falling when they're older, and importantly, you can increase the muscle mass and strength to stop people going on to becoming frail. So I think it is a condition on its own, but it can lead to frailty. And that's the way I tend to think of it. It's the same thing with frailty. All frail people are sarcopenic.
And the cytokine IL-6
Yeah, well, the cytokines clearly play a role in sarcopenia. Less of a role, perhaps, in frailty directly, though they do play a role in it. But if the inflammatory cytokines are elevated, you're going to have muscle loss. And obviously, you get this with disease. One of the things that you have to differentiate from sarcopenia is cachexia, which you see in people with cancer, with severe disease, whether it's gallbladder disease or anything else. So I think it's important to recognize that you can find treatable diseases that if you stop, you can stop them going on, sarcopenia going on to cachexia, but also that a lot of cachexia occurs with aging where a low dose of increased cytokines might be important.
Here, a question said, when do you use it, the geriatrics assessment? What experience did you make with it compared to other assessment?
So for about 30-something years, I've been doing the general Larry Rubenstein geriatric assessment, which is long, has a lot of stuff in it, and starts with looking at the IADLs and ADLs. In the last 5 years or so, what we realized is nobody in primary care health professions has time to do that. And we've cut by half the number of geriatricians we have in the United States since I've got my geriatric diploma, which was about 28 years ago. So we have to recognize that we need to have something that is easy for primary care physicians to use. And because of the shortage of geriatricians, we also have to be able to guide them into what they should look for and treat where possible. We have been very successful with this. Our greatest example of Perry County, which is 100 kilometers south of St. Louis, and Kirksville, which is about 120 kilometers north of St. Louis. But all over the world, in fact, we've seen people doing it. They've been very successful at the National University of Singapore as well. But it really is aimed at not the super specialist. The super specialist geriatrician should get the patients who nobody knows what to do with or who have multiple geriatric syndromes. But with the average geriatric syndrome, what we found is developing exercise programs in particular is very important, and making sure that we look carefully for the treatable causes of, say, frailty and weight loss. And in the case of people with cognitive dysfunction, making certain that we have a program to support improving their cognition. This should be done with exercise. We've found that we've been extraordinarily successful, again, developing the cognitive stimulation therapy program, done predominantly by social workers and occupational therapists. It has excellent outcomes in our hands, and we've done this both in nursing homes as well as in the community. And I think that it's developing, and the role of the geriatrician has to become, we will develop these programs in the community rather than that we will see lots of people, screen them, and then still not have the programs. So developing programs that are good for treating all these simple geriatric syndromes, I think, are very important, and training the physician in private practice how to at least look for the obvious treatable causes and treat them, as well as the exercise, the CST programs, and things such as that, I think makes all the difference. And that's where we've been going in the last decade, but particularly over the last 5 years or so. And as I say, our example is Perry County, where their program's run by a social worker, and she's put the team together, and the physician gets asked if they think there's a medical problem, but it's all done by an interprofessional healthcare team who take each piece of it and do what they're supposed to do. So if the person's got a problem with anorexia, the dietitian comes in and does that. So I think that's where the future is, quite honestly. I think it's very exciting. And I mean, I'm sure you've done better than we've done at getting all the people in primary care to look at geriatric syndrome. So I've spent my life wondering why I've tried to teach people this, because they never seem to do them. Since we've been doing the RGA, we're having much more uptake with this in the primary care setting.
Dr. George Yuri from Argentina asked you how your opinion on weight loss in demented people with the use of nasogastric or gastrostomy tubes.
Okay, so we tend to think that the use of tubes, and the data suggests in demented people that if you put in a tube, they die at the same time, if not quicker. So what we have to do with the demented people is develop food preferences that they will take, including finger foods, soaking foods, but also getting someone to help feed them on a regular basis. It's not always easy, but the outcome seems to be about as good with demented people as it is putting in a tube. Where you have diseases that require a gastroscopy tube, that's different, and obviously there are places where we need to do that. But certainly in dementia, we have moved almost totally away from putting tubes into patients with dementia, because the data we've seen, our own data and that of other people, suggests that it makes very little difference.
Dr. Scipioni said, I believe that any evaluation of the status of an elderly person must also consider other situations that make them dependent. And they are social disability, affective disability, cultural disability, and economic disability.
So certainly he's right. The environmental ones are absolutely key. Maybe, I don't know which country he's coming from, but in the United States, getting social things fixed. We live in a country where if you're rich, you can have anything done for you. But if you have no money or you don't have a lot of money, nobody does anything for you, which is why the United States is way down on the death rate for older people. And we just don't care. I mean, we can claim we care, but some of you might have noticed we had somebody called Trump as our president, and he cared not at all. But even the good Democrats who try to care don't put the money into it. Our system is not set up for a good social system. And the Americans listening will be screaming at me and saying I shouldn't say this. But if you deal with old people, you realize that there are lots of failures in our social system. The depression or dysphoria one is totally right, but we pick that up if we do the fatigue and we do the cognitive stimulation therapy. We can pick up most of the people who are going to be depressed. So if somebody has fatigue, we go ahead and do the PHQ-2, looking for depression in that population. Again, with mild depression, most probably you're best off in older people doing psychological involvement and trying to put groups together. And it's only as your depression gets worse that the drugs seem to really work very well. We also, as you saw, have the alone scale for loneliness, and most people who are depressed score very positive on the alone scale. We find that somewhere around 20% of older people are lonely, and one of their biggest causes is that they are at least dysphoric, not necessarily depressed. And there we like to use the Finnish approach of a circle of friends, where you bring a group of people together, you bring them together regularly, and they discuss things. What's important there is you need to have somebody who is a facilitator, who's watching who talks all the time and who doesn't talk at all, and making sure that the person who talks all the time is quietened down a little bit, and the person who doesn't talk gets the opportunity to be involved. But you can make a big difference. And we've been very successful using the Finnish approach in St. Louis.
Thank you. Dr. Sara Aguilar Navarro said, should aspects such as loneliness and or social isolation be included in the brief geriatric evaluation?
So the answer, as I think you saw right at the end, we had the alone scale in there. I think that every older person should be looked for to see if they are lonely. And as I said, in our studies, what we're finding is 20 to 30% of older people are lonely. About half of them have depression. The other half just are lonely because they don't have good interactions in the community. And this is true even in our long-term care setting. And so those people, we need to develop programs for them. Otherwise, they go on to become very depressed. They also don't do any exercise. They don't do anything. So it's very important to look for the lonely. And the Alone paper, our quick screen, has just been accepted in the Journal of Nutrition, Health and Aging. It's very quick to do. And because it came later than the rest of the rapid geriatric assessment, it's not in it as a primary thing. But I do think that the social worker should, when we see patients who are older, do the Alone scale. And if they're lonely, get them into groups to try and decrease their loneliness. And again, getting people who are alone don't do much exercise. So putting them into an exercise program alone as well. We have, I think, a long way to go, much better in Europe, better in some parts of South America, and better in, say, Singapore and Hong Kong in developing programs for older people where we allow them to interact much more with other people, and we also have exercise programs. Those are the center to prevention of problems in older age, and I think we really, at least in the United States, don't do it well enough.
Dr. Yuri said at the Rodriguez Ortega Vicente Lopez Geriatrics Hospital, Buenos Aires, we are developing a kinephylaxis program for the elderly community population, BCI, fall prevention with talks and activity by kinesiologists and Tai Chi. Do you agree with this model?
Yeah, so as I was saying, I think it's a very important model to have. I think that, I mean, obviously, anybody can benefit from almost all of these things. But I think that by using the RGA to pick up the people who are either sarcopenic or who are frail or basically have some central nervous system problems, memory problems, or the people who are lonely, making sure in particular that they get into these programs. What is often the problem with the hospital-related program is it's short. It will be 6 weeks or 3 months. And these programs, clearly to be successful, have to be lifelong for the older person. And that, again, is where we run into trouble. It's putting together the social things with the medical things to get a good outcome with an older person.
Alfredo Jorosh, why are you optimistic with computer assistant?
Am I optimistic with them? Well, yes and no. Okay, so I have spent the whole COVID time developing a annual Medicare wellness visit. We can bill for that in the United States. It's totally computer run. Exists at the moment, and we're starting to test it out. I think if you recognize that they often have to be done with a family member, so you can do these and you can require, the way we've set it up, it gives all the treatments, it will actually send the person to the appropriate healthcare professional or physician to be looked after and get their treatment. So it can do all of this, but it does need, particularly in the older person who might have some cognitive difficulties or is not very good with a computer, help from a family member or a nurse or a social worker. But I think it's part of the future. And I think COVID has taught us that that's where we're going to go. And, if you want to get through to large numbers of people, computers will do it for us. But we've got to train people to believe in computers, and we've got to make sure that people know how to use computers. And then we've got to train the healthcare professionals when people get positive results from the computer to know what to do with those positive results. Having said all that, I know that there's no problem in Argentina because you guys can do anything compared to what we can get done. But realistically, to be fair, that's a huge amount of work, but I think it's where the future is. Geriatrics is an interdisciplinary, interprofessional program, which we've got to put together and make work in a connected way. And that is, as I say, at least in the United States, very hard because it's difficult to get a lot of things paid for in the community that are follow-ups. And you need to have that. You can't expect that people are going to go and pay for stuff that they don't even think they really need. So I think we need a support from the government to do this stuff, and it needs to be out there. And we're going to need interprofessionals who are trained specifically in doing the elderly-friendly things, and then we will have much better outcomes for older people.
Okay, the last one. Christian Müller from Germany say, you mentioned that an interprofessional team take care of the patients. Do you have ambulatory interprofessional teams in your department?
Well, now, how do I put this? We have very small ambulatory interprofessional teams in our department. We do much better with nursing home patients because we do a lot of nursing homes and we work very closely with interprofessional teams there. I mentioned Perry County in particular. So Perry County, we do a yearly talk on geriatrics, a conference for people in all the different professions. And the social worker, Janice Lundy, came to one of our talks, and she heard me say exactly what I said today. And basically, she said, that's a wonderful idea. We've got to do it. And I said, yes, you've got to go out and do it. And I thought I'd never hear from her again. So they run now roughly about 20 programs a week for people in their community. And they give both the cognitive stuff and the exercise stuff. They also have interprofessionals they screen for the RGA and they send them to the dietitian. Or if they've got a major physical therapy program, they don't send them to 6 weeks for the physical therapist, but they send them to the physical therapist till they're functional, and then the physical therapist sends them into an exercise program. So I can tell you that in Perry County, we have a wonderful program. It has nothing to do with our university, except that the social worker gives me credit for telling her that she can go and do this. And we've gone down there often and talked to the administrators and told them what a wonderful job they're doing. But what I'm telling you is it can be done. You've got to find somebody who's excited about it. And I'm not certain that the physician has to be the central person. In fact, I'm pretty certain you do much better if you can find a primary care health professional who wants to do it and wants to put the program together and can find a way to get it funded.
Thank you. Thank you very much, Dr. Morley. It's a very pleasure share this conference with us. Thank you.
Well, thank you, Julio, and it was great fun to be on the program with you. I hope some people found it useful. And if they didn't, then they need to go and learn what they should know, which is not the basic geriatrics, but the very simple parts. And that's what I care about. I think I've failed, I mean, I'm 76 now and I can't find programs like this for myself, let alone for anyone else. So let's be realistic about this. We've got a long way to go to create great gerontology programs for older people throughout the world. Thank you very much for putting this together.
Thank you. Thank you.